Thank you so much for these wonderful arrangements. And I'm really happy to see that the young crowd, that is, you are the tomorrow. So thank you with this small intro to all of you. Pseudoexfoliation syndrome and the glaucoma, which is quite common to see in our population. It is, yeah. So pseudoexfoliation is quite common to see in Indian context as well, though it has been mentioned it is more common in somewhere else. The pseudoexfoliation glaucoma can be, most of the time we used to think it is a primary glaucoma. It is basically a secondary glaucoma. That is why they have included the topic here today. It can present as both ways, open as well as angle closure disease. Basically, the pseudoexfoliation material is present in the anterior segment, which blocks the trabecular meshwork and then causes the glaucoma. Why is it so important? It is the high risk of rapid progression and worse prognosis if you don't treat in comparison to the primary open angle glaucoma. If you look at the prevalence, it is more common in the Nordic countries, Mediterranean and South Africa. I'm not sure why South Africa is very different from other African countries. Typically, it is commonly seen in above 60 years in their population, but in our population, it is more common to see even in the age of 30 plus or 35 plus. Many of you must have come across this in our context. Looking at the genetics, it is the LOX-L1 gene with the polymorphisms have been implicated for this problem. It is basically an extracellular matrix, which mostly is derived from the basement membranes of the lens, iris, and the ciliary body, which blocks into the trabecular meshwork. And you can see the histological appearance. And it is nothing very complicated to understand what is the basic mechanism in the glaucoma. It is basically the trabecular meshwork is getting obstructed with the fibular material. There are many ocular signs where we have to look for, starting from the iris, pupillary margin on the lens, and at the gonioscopic angle. Basically, it is something similar to our primary open angle glaucoma. There is not much of a symptom, so we call it as an asymptomatic disease. The main differential diagnosis goes with the primary open angle glaucoma. Sometimes we might not have picked up the PXF material in the pupillary margin or over the lens. So we might diagnose this as a primary open angle glaucoma. Also, sometimes it is possible to miss the pigmentary glaucoma. That is where we see typically the Krukenberg spindle. And I will show you the gonioscopic picture. And of course, the steroid-induced glaucoma, where Venki was mentioning in the morning. Quite common, it used to be. Now it is much restricted. So it is not that uncommon to see something like this. And then we miss out the PXF material and the pupillary margin because the pupil is small. It's quite easy to miss out that pseudoexfoliation material if you have kept your slit lamps in a low mag. And just increase your magnification and then you start picking up the pseudoexfoliation material in the pupillary margin. And please keep looking at the iris pattern, how the iris pattern is. You can start seeing that the atrophic areas of the iris. So that is what is very critical. The next thing is, if you have seen the pupillary margin, look at the pupillary rough in comparison to the normal people. I'll just show you a little enlarged picture. Look here between this one, the normal pupillary margin versus the pseudoexfoliation pupillary margin, how the pupillary rough is. And also, if you see the adjacent area of the iris, you can really pick up those atrophic areas. So this is a classical pseudoexfoliation that you must be able to pick it up. Sometimes you will be able to see even the blood vessels, prominent blood vessels, iris vessels. You might be mistaking that as for your neovascularization. The next thing is looking at this, the three zones, the PXF deposits, and there is a clear zone, then there is again a PXF deposit. It's not very clear in this picture, but I'll show you. This is just to show you in the early cases how it appears. You can see the pupillary margin, pseudoexfoliation material is there, and you see the clear margin, though the pupil is not fully dilated. The picture appears to be fully dilated, but it is not that well dilated. That's why you're not seeing the what is inner. And you see the central disc, clear central disc. This is very beginning, but you see this here. You can see clearly how the outer rim is pseudoexfoliation. Pupillary margin, the outer one, and the in between the clear zone. That is because the pupil is dilating and constricting. That is the reason. And then you have the central zone again. Just to magnify that, you can see very clearly in this outer, the central zone and the disc. So looking at the gonioscopy, of course, you can use any kind of a gonio mirror if you want to really see that. But I prefer to use the trabeculoplasty lens where you have a beautiful pictures can be taken and large area of the angle can be visualized. So two important things. One, don't get confused with the pseudoexfoliation and the PDS. That is the pigment dispersion syndrome. You can see this on this left side for me is the pseudoexfoliation. That is called as a sample lysis line. In your Kahoot, they may be asking you a question. So you have all of you have to give a 100% answer. That is a sample lysis line that is on the what do you call on this wall base line. Okay. Next, you see the PDS. That is the trabecular meshwork. 360 degrees. It will be the same. Just give you a little bit larger picture. That is the sample lysis line in pseudoexfoliation glaucoma. Why it is important for you is when you are planning to do a laser, if you are going to do the laser on the pigments, that is the sample lysis line, SLT, it will not work. So you have to do the SLT only on the trabecular meshwork. That is the reason why I wanted to really show you this. Sample lysis line is on the small base line. And pigmentary glaucoma, you can see the trabecular meshwork is completely pigmented. It will be something like this band, 360 degrees. It will be uniform in appearance. Next thing is seeing these filiform vessels in pseudoexfoliation is extremely important because these vessels are very friable. The moment you put the side port, it will start bleeding. As soon as you have the hypertony, it will all start bleeding. So that is typical. So you look at the gonioscopy, look at the filiform vessels in the angle with the microhyphema sometimes. There is a typical appearance of filiform vessels and the microhyphema. So looking at the fundus, all of us do use the 90 diopters, but I really hate doing 90 diopter examination because you miss 90% of the findings when you're using your 90 diopter. So I prefer to go with the fundus photograph actually in every given patient. This is the comparison for you. So looking at the pseudoexfoliation and the optic nerve head, how different it is from primary open-angle glaucoma or other disease is always we look at the cup and the neuroretinal rim loss. But in pseudoexfoliation glaucoma, you have to pick up the pallor of the neuroretinal rim. The main reason is the IOPs run very high, something like an angle closure disease. The IOPs run very high with the high fluctuations. So the ischemic optic nerve head is a associated sign in a pseudoexfoliation glaucoma because when you are doing the visual fields and also when you are doing the OCT, the picture will be completely different than what you see with your regular primary open-angle glaucoma. This is a comparison. In pseudoexfoliation glaucoma, always the asymmetry between the eyes is pretty high and the pallor of the neuroretinal rim one has to remember. The asymmetry means many cases of pseudoexfoliation will have only one eye glaucoma, the other eye will be completely normal, but within the next 5 years, there is a high chance that the other eye also develops into glaucoma. Again, in pseudoexfoliation, though we say that it is quite common in an NTG, but in pseudoexfoliation, again, the disc hemorrhages are quite common because there is always an ischemic mechanism also plays in this pseudoexfoliation. Measuring the intraocular pressure, what is that you really need to understand is, you see here, this is one of our patients whose intraocular pressures were like this. we know the diurnal fluctuations are pretty high. Though this patient wasn't treated, you can see how high the fluctuations are. Morning IOPs are in 35 and evening IOPs are in 13. So even if you have not treated, the patient will have a normal IOP and you might think that the patient is normal tension glaucoma picture. So in pseudoexfoliation, the diurnal fluctuations are pretty high, one has to understand. And sometimes the water drinking test might help. These are all the mechanisms where the water drinking test, why there is a possible elevation in the water drinking test. So if you really see that, this is one of our patient again, where the water drinking test has proved that the other eye has shown up higher IOP fluctuations. So this could give us an idea how the prognosis is going to be for this patient. If you just treat only by medications, probably these patients need more of a surgical attention. So then looking at the visual fields, what is that you really see in the visual fields in pseudoexfoliation glaucoma is how fast is the progression happening. So we look at basically looking at the cluster analysis. If you have your octopus, it will be really useful for you. Look at the cluster, the central 10 degrees of cluster, how fast the patient has a progression. The central 10 degrees cluster, especially the inferior quadrant, if it is fast progressing, then the patient will have more limitations in his regular activities like walking, reading the newspaper, walking, writing, all that will have a high possibilities of progression. You look at this progression, how fast this progression has happened. The moment the patient stops or not using regularly, the compliance is poor. The progression is much faster than in any other case. This is the progression chart. Both the general as well as the localized progression is pretty high because these patients will have possibly the lens thickness is also higher in some of the cases. But the problem is they develop very quick cataract also. So this is the mean, diffuse loss as well as the local loss is pretty high. So looking at the VOCT, what is that you really look at VOCT in pseudoexfoliation glaucoma? As I mentioned earlier, it is not only the glaucomatous changes you tend to see, but looking at the MRW, that is the minimum rim width. Because of the ischemic changes, you see disproportionate appearance of red zones. So we can go a little deeper into the VOCT later because I have to explain each and everything, so I am not explaining it now. Because of this ischemic area, it shows the more MRW loss, and also there is a loss in the RNFL area as well, disproportionate to the cup what you see. That is again a typical of pseudoexfoliation cases. And this is the pattern appearance of posterior pole. That is your ganglion cell layer loss. Again, it will show a little higher, but this is little bit of an artifact is there. This is a movement error, movement artifact is there in this. And also you see the RNFL loss. It is a pretty high RNFL loss again. So posterior pole, you can see that how fast is the progression happening from normal. This could happen within in no time, like within an year or so. So the progression is much faster. So you have to use your trend analysis in your VOCT to see which area, like it could be superior, it could be inferior. Always select the area of your interest and see how fast is the progression happening. So always the structure function correlation may not be the typical of primary open-angle glaucoma. It will be a little different from primary open-angle glaucoma. So you got to understand that. And looking at the biometry, why is biometry may be useful in some cases is you can look at the lens thickness, and you may have some patients with the shallow chambers, some patients with the deep chambers as well. The moment you see the shallow chambers in a pseudoexfoliation or deep chamber in the pseudoexfoliation, that means there is a subluxation of the lens. So this could be one of your another cohort questions. So medical management, remember, as the patients have a very high IOP fluctuations, so you got to treat it a little bit more aggressively. I'm not going to the depth of this, but usually it is better you start with the prostaglandins, but many times you may require more of a combination of medications within 6 months to 1 year time itself, maybe a couple of medications or 3 medications, but don't go over 3 or 2 medications because these patients will have a high fluctuation. So you might required to have a surgical options. So lower the intraocular pressure in exfoliation is very useful. Looking at the SLT, definitely SLT is a way that some of us can approach, but there's always a spike in the IOPs in about 10% of the patients because of the hyperpigmentation, but they do respond reasonably well in elderly people like 50 plus, but you have to see how much is the pigmentation happening over there. Looking at the surgical option, what is the common problems you have is the small people, weak zonules, shallow or deep AC, which are both are quite disturbing to us. So this is a small people. So people, we have given the dilating drops, but it is not dilated. So other option is, if how many of you are here from Arvind? Can you just raise your hands? So you have your new dilating drops in your kitty now. That is I can remember the only name as trade name as Pinocaine from other company. So that is with the phenylephrine, intracameral phenylephrine with the lignocaine. So the moment you use, you can see the reasonable amount of dilatation. You can dilate with many ways, but I never used hooks. Probably I've entire 33 years of my life, I've used probably 3 or 4 times only I've used the hooks. So you can see that the dilatation is reasonable. And most of us in glaucoma surgeons can manage this size of people without much of a dilating hooks. So how effectively you can use is using the blue is not to stain the capsule, basically to make the the anterior capsule much thicker, so that when you're doing the rexis, we can do it more comfortably. Otherwise, it is a little difficult. So you can see this is a reasonable size people where you can comfortably operate. So this is the next patient. What is that you really have to see? The moment in Arvind or even outside Arvind also, when you have the volumes, you might not have seen the patient. The moment you see the anterior chamber, let me just little forward. I think. So again, I'm just using the Pinocaine. Pinocaine, I use it in every patient. So the pupillary dilatation is sustained. It is not a very dangerous drug to be used. Not your diluted atropine. Okay, this is a okay. Till this, everything was okay. I didn't probably hear the sister saying what the other eye was. So I went in, you can see the pseudoexfoliation material in the pupillary margin. How many of you could really pick up the exfoliation? You see that? So you can see how much of the phacodonosis was there. So what will you do now? How many of you will proceed with the phaco in this? Okay, Sarmila, Neetu, Venki is still not raising his hands. Okay, Swati. Okay, so I didn't proceed with the phaco because it was very large. It is not for you to put a CTR. So I went in with the superior rectus suture and SHS, and then I could put the iris claw lens only. Because other eye was iris claw lens, I didn't listen to the sister. So we should not go ahead. It is not how good a surgeon you are, but how good a visual outcome that you can give it for the patient is the priority. It is not your surgical skills. So mild to moderate glaucoma, if you have, this is a controversial area that I'm going to throw it here, maybe a MAGS. But when you have moderate to severe disease in pseudoexfoliation glaucoma, don't even think. If it is not under control, go with the proper trabeculectomy with the mitomycin C. So what is that you can expect in a pseudoexfoliation is the prognosis wise, it is not equivalent to POAG. It's much more rapid progression because of the higher fluctuations and high IOP levels. Surgical risks, which you have seen already. So key takeaways from this topic is pseudoexfoliation is a secondary glaucoma with a distinct pathophysiology. Look for PX of material without missing it. Monitor closely as it has a high risk of progression. Surgical caution has to be taken care. Thank you so much for this wonderful opportunity. Thank you.